Good evening, everyone. Can I welcome you to the next in our series of the Royal College of Surgeons of Edinburgh COVID webinars. My name's Rowan Parks, one of the Vice-Presidents of the College, and it's great to have a super panel with us tonight. We're focusing very much on training, and particularly trainers and supporting surgical trainers, especially during this pandemic and COVID. So it's great to have a number from the Faculty of Surgical Training, Faculty of Surgical Trainers, David O'Regan, the Director, Gael MacLean, our Secretary. It's also good to have Lisa Hadfield-Law, Surgical Educationalist, many of you will perhaps know, and John Lund, who I guess most will know as current Clinical Director of ISCP and incoming Chair of JCST. It's also my honour and privilege to be able to welcome Ceci. Ceci Hotnew is a paediatric surgical trainee based in Edinburgh, but she has, she's travelled all around the UK in various posts and trained in the UK. But she is also a Scottish Clinical Leadership Fellow and has taken a year out of her paediatric surgical training to do a leadership development programme with NHS Education for Scotland. But as part of that, she is hosted by the Royal College of Surgeons of Edinburgh and by NHS Grampian for some of her placements and activities. So she's joining us to keep us honest and to keep us right and to ask questions of the panel as a trainee, because this is all about what we're doing for trainees at this challenging time. So I'm not going to say too much more other than to welcome everybody. We hope we'll stimulate a lot of discussion in the Q&A, and hopefully you'll use the Q&A chat box once we get in. We're going to hear a few presentations first of all, and hopefully that will stimulate some thoughts and questions and hopefully some good advice. We are focusing a little bit on the Faculty of Surgical Trainers, and I'm going to start and ask David to give us a bit of a background and introduction to that, and then we'll work through a number of others of the panel who've got contributions. But David, over to yourself.
Thank you very much, Rowan, and thank you for inviting the faculty to present this evening. I feel privileged to be able to continue the sterling work of my predecessor, Gael MacLean, who established and conceived the Faculty of Surgical Trainers in 2014, and I was deputy when the Constitution was ratified. Our numbers for the faculty increased by 7% over the past year, and by the end of this year, we hope to have a membership of 700 people spanning 24 countries. 14% of our membership is overseas. The target for training is the intersection between competence and confidence. And I support and laud the initiatives of Let's Remove It and Hammer It Out to remove bad behaviors in theatres, because that confidence is very precious and can be easily destroyed. In times of COVID, we've realized there's a lot more to training. It's been difficult for everybody, but I think it's been a useful reminder of the fact that our responsibility as trainers is nurturing the future of surgery. And it's highlighted the need for the trainer to have soft skills, self-awareness, team playing, communication, ability to reflect, and learning. Emotional intelligence is much better than IQ. But I go further and say, actually, maybe it is LQ, and there's more love in it and letting people be. I think it's important that training should be a privilege and should be a joy. It should be fun. And personally, I'm concerned the system is removing that fun, and I want to reintroduce it and remind people that we are working in a very privileged profession. The relationship with a trainee to the system is complex with a number of actors in that system. And what is missing in this are feedback mechanisms. Yes, it's there, but people aren't aware of it and people aren't using it. And we're going to come to that because feedback is the breakfast for champions. And it's thanks to my predecessors for establishing a framework for good trainers and excellent trainers that we've been able to define the behaviors and expected attitudes of the trainers. We need to grow that and encourage people to use the skills and to grow themselves to become better and excellent trainers. Because in the end, what we're really looking at is the capability and competency of the trainee drives the satisfaction, reputation, and recommendation of the trainer. And together, they are responsible for quality service for our patients. Get this right. We need to, now and tomorrow, to ensure that we have a safe, effective service for the patient that offers a good experience for the trainer, trainee, and the patient. And that is the obvious return on investment in investing in good trainers. And chatting to our American colleagues, they raise their eyebrows when they hear that we have 0.25 PAs per trainee in our job plans. If we want to professionalize the surgical trainer, we'll need to recognize, and the system needs to recognize, the importance of the trainer in all of this. Thank you very much indeed.
Thanks very much, David. So a nice setting. We should be all focusing on ensuring training is enjoyable, is fun, but also engaging. And you know what the Faculty of Surgical Trainers stands for is to empower people to do that and to deliver that. We're going to ask Gael perhaps to go next and to give a flavour of something that the Faculty of Surgical Trainers has established and done to try and give some guidance in this area. So Gael, can we hand over to you to develop our thinking on this? And chatting earlier just before we started, Gail's very happy if anybody wishes to come in with some questions during her presentation or talk. So again, please feel free as we start going through the chats in the talk to ask your questions and put them in the Q&A box. In the bottom right, if you scroll your mouse, you should find a Q&A box. Please put them in and we can try and forward those on to Gael. But Gael, I'm going to hand over to you and look forward to what you have to say.
Thank you very much, Rowan. Well, it's an absolute pleasure to take part in this today. And I'm just going to share my screen with you, which should be coming up now. So the Faculty of Surgical Trainers, So the Faculty of Surgical Trainers at the College of Surgeons in Edinburgh set up the 7 frameworks of standards for trainers. And each framework area, I'll go through in detail. But the first edition of these frameworks was launched by the Faculty of Surgical Trainers in 2014. It was then endorsed by the Joint Committee on Surgical Training and the General Medical Council. And I think it's fair to say that it's really seen as the gold standard for surgical trainers standards throughout the UK. In 2016, the GMC implemented the process for formal recognition of all trainers in surgical care. And on the back of that, the following year, the FST launched their 2nd edition of standards. So each framework area was designed so that it would have no more than 7 elements, just not to overcomplicate things, but 2 of these standards would be for the excellent trainer. The standards should focus on areas that are clearly indicative of effective and excellent behaviour rather
Gael, can you hear us? I think you've frozen.
It's frozen for some reason. Sorry about that. Oh, there we go.
There we go.
So here are the 7 frameworks. This is not the exact, what they're exactly called, and I'd direct you all to the FST website, a part of the College of Surgeons of Edinburgh website to get the exact wording of this, but this is a summary. The first one, safe and effective patient care. then looking at the learning environment, so important in surgical training, then teaching and facilitating learning, assessment and its role in surgical trainers, educational progress of the trainee and also the trainer, personal and professional development, and continuing professional development as a trainer. So looking at the first one, ensuring safe and effective patient care through training, well, obviously trainers really need to demonstrate the highest standards of safe surgical care in their practice when they're teaching and at all times, and provide graded supervision appropriate to the trainee stage of training. And that really only comes when you develop a relationship with a trainee and you really know what stage they're at, and using training opportunities to improve the quality of care and patient safety. And also just to ensure that the trainee has a safe and thorough induction to the unit that they might be working in, not to assume that it's going to be the same as where they've come from before, because sometimes there are significant differences. And they do need to have a named supervisor available in all theatre sessions and clinics. And it's important to make sure that the trainee really does recognise who that trainer is. And sometimes that has to be said quite explicitly. The second standard for trainers is establishing and maintaining an environment for learning. It's very important that the trainer demonstrates positive attitudes and behaviours towards training and the trainees, and provides the training opportunities for all trainees. And this has to be training opportunities, not just observing. It has to be education in its true sense by organising the training opportunities. The skilled trainer will be able to select the opportunities to develop the trainees' knowledge, skills and attitudes appropriately. And it's important in terms of the environment, thinking of the larger multidisciplinary team, so involve the wider surgical team in the training. And for example, it can be very useful to set the scene right at the beginning of a theatre session when the WHO checklist is read out, and when you go through the cases, to point out which parts of the operation or which operation your trainee will be the lead surgeon. That can be very useful to set the tone in the environment that this is a training opportunity. Teaching and facilitating learning. It's important for a trainer to plan and implement the suitable learning and training activities for all the trainees, again appropriate for the stage in training. And this, of course, has been very challenging during the COVID period when opportunities are just less. I mean, a lot of trusts, the lists were much fewer cases on them with all the PPE that was used, especially in the early days of the pandemic. And now that we have testing for patients, we are seeing, certainly in the trust I work in, we're seeing a lot more cases coming through, so there are more opportunities. It's important that the trainer knows the curriculum outcomes for the trainees, so they really do need to be conversant with the ISCP and the curriculum for their actual for their trainees, and be able to utilize a range of teaching and training techniques in a variety of clinical environments. And again, during the COVID, in the COVID era that we work in just now, sometimes teaching and training techniques might not be what they were before. And it would be good to talk about in our chat after my presentation, where there have been other opportunities that have come up in COVID that might not have been present before, especially using distance learning as we're doing tonight. Trainers also need to demonstrate exemplary knowledge, skills and attitude in surgical training, and engage in the development and delivery of training beyond the immediate surgical workplace. And a very good place to go and helping development of that is with the FST, the Faculty of Surgical Trainers, who provide resources and have a very good online conference coming up soon in a couple of weeks. So that's a really good opportunity to develop your own skills and knowledge. The fourth standard is enhancing learning through assessment. So it is important that the trainer is actually able to use the assessment tools. There's nothing more disheartening for a trainee to be told by the consultant supervising them, I really don't know how this website works, and that's just not acceptable. You need to be conversant with the tools of the trade, and the assessment tools are just as valid as any other tools, and to progress trainees' performance through that. And utilising, especially work-based assessments and CBDs, for example, can be a great opportunity to really sit and reflect with a trainee and talk through events. You need to regularly observe the trainee's technical and non-technical performance and provide regular, appropriate and very specific feedback on what they've actually done and what they've achieved. And also to support a trainee in preparation for postgraduate exams. We've all been there, and we can sympathise and really support them through that. The fifth one is supporting and monitoring educational progress, quite similar to number 4, but important to set appropriate goals and then review the trainee's progress towards these agreed goals, again with a good knowledge of the curriculum available on the ISCP website. Regular meetings with the trainee to review and monitor progress. I personally find it very useful when I take on a trainee to put dates in the diary for the forthcoming year or however long they're with you. You can always change these dates, but I think it's very good for the trainee to see that there will be benchmarks of reflection and assessment in a regular manner, rather than doing it slightly ad hoc. So it needs to be able to use the ISCP or equivalent to monitor and record progress, as I've already mentioned, and also be able to identify and engage with the trainee in difficulty. That in itself is a whole presentation in itself, but it is important to be able to recognize and engage that. Number 6 is guiding personal and professional development. And the most fundamental thing for this is to act as a role model and a source of guidance for professionalism in the surgical workforce. You have to be living it, and you have to lead by example. By, as it says in the handbook, demonstrate exemplary professional behaviour. And it's important to build effective supervisory relationships where you can balance confirming progress with the trainee, but also saying when a trainee needs to be challenged to move their skills forward. And also to set and maintain personal and professional boundaries, as is enshrined in good medical practice. The final framework is continuing professional development as a trainer. Again, the FST here has a great role to play, and I would encourage all people listening to sign up and join the FST. We'd love to have you with us, and this will help you to continue your professional development, to be part of this group of people who are passionate about training. Engage in self-development as a trainer to improve your own performance and promote development in others. It's important to maintain up-to-date professional practice in context in keeping with good medical practice, which we're all familiar with, and also actively challenge poor practice and champion positive change in yourself and others. And that is a very brief but comprehensive summary of the 7 frameworks that are used as standards for trainers and developed by the FST.
Gail, thank you very much. I think really helpful introduction to the topic. I guess for some of the trainers perhaps on who haven't heard of FST, can they go and see the standards document? Is it accessible? How can they sort of pull it down? Is it publicly available?
If you go on to the College of Surgeons, Edinburgh College of Surgeons, and then go to the FST part, it's all easily accessible there. So yeah, very, very easily accessible.
Okay, so a really good reference document, and it's all about standards and what trainers can do to think through these various domains. And you covered a huge number there, so no doubt we'll maybe come back to some of these. But it's now thinking about how we put this into practice, I guess, is one thing. We're going to hear from Lisa first of all, and then John Lunn from an ISCP perspective. But Lisa, without any further introduction, can we ask you to take the next bit? And I think Jerry's going to put something up and run it hands-free, as it were. So we'll listen to that, and then we'll proceed. Thank you.
These standards, created by the Faculty for Surgical Trainers, and more particularly Craig McElhenney and David Pitts, are irrelevant really without having any evidence. So what evidence can we collect for ourselves and for future recognition that will also help trainers help trainees to progress? Lots of people are struggling under local pressures again at the moment, so we do need to find ways to manage minimal time and fluctuating opportunity. Well, I've got 2 suggestions for you tonight. Number 1, have a bash at the MCR's multi-consultant reports and start establishing feedback conversation rather than just feedback monologues. Let's start with the MCR. Why? Because I'm finding the MCR is really helping me and trainees and trainers I work with, because it helps us get ready for August next year when we're going to have to do them. It'll help us iron out wrinkles, and T&O participants on the new virtual AES training have found 5 important ones already, and so we can sort those out before next year. It'll help us find trainee gaps, because it's human nature for trainers and trainees to focus on their own personal areas of interest, or just the opportunities that come up right in front of our nose. MCRs help us to maintain a much better overview and make sure we don't leave any holes. And number 4, I think it helps structure for struggling trainees, so particularly trainees who've fallen behind because of illness or difficulties. MCRs have helped us set priorities and not get lost in the detail of individuals' work-based assessments. How? Well, find a volunteer trainee first with as many as possible of their clinical supervisors. Then meet up with the clinical supervisors without the trainee for the assessment. And you can meet in face-to-face, but virtually I think is probably even better in this situation. You be the consultant chair and then use Chrome to log into your ISCP account, as I have here. And then up to your trial MCR, which appears at the top, acknowledge that it's just a trial version and will not be held and cannot be used for ISCP. I'm going to use my fake trainee here and then either create an MCR or I'm just going to carry on with this one here. And so you can see that I'm the lead clinical supervisor here, and I've got a list of other contributors to this MCR. I can add a few more if I want to, and then I'm going to save and continue, and it takes me straight to the generic professional capabilities. So I'm going to find the relevant ones for my part, and I'm particularly thinking about areas that might need some development. So I'm not necessarily going to put something in every single one of these boxes. I'm going to look for the really relevant ones for Mike here and put in examples of where development might be required. Save and continue, then straight to the capabilities in practice, the 5 capabilities in practice here. And again, I am going to put something in every single one of these boxes. Something here, and certainly assessing the supervision levels for each of these CIPs is essential. So I'm going to put something in each of those, and then I'm going to save and finish again. It won't do it now, but it will come up with a summary report, and then I will just PDF that, print it out, and use that for a discussion with my trainee. So trainees can do the same and then PDF and print out their self-report and use that for a discussion, reflect on the whole lot, and if you like, upload the self-assessments to your other evidence or the miscellaneous section if you like, but you don't have to do that.
Now, David's already mentioned that feedback is the breakfast of champions. And debriefing, feedback and coaching are three sides of the same coin. And we need to broaden our range of tools for learning conversations. And I want to bring to your attention the R2C2 model. It's an evidence-based reflective model, and it really helps our trainees through driving a shared agenda instead of just bestowing pearls of feedback wisdom and inflicting them on our trainees. There are 4 elements. 1, rapport building. So crucial and often forgotten. Just starting with the question, how have things been going? Number 2, reactions. Asking the question of the trainee, what were your initial reactions to the MCR? Did anything in this report surprise you? Number 3, content. Was there anything that struck you as something to focus on? Was there anything in the report that didn't make sense to you? And then finally, the coaching bit. If there's just one thing you would target for immediate action, what would it be? What might be your goal? Who or what might help? And then following that proper conversation, the trainee can then capture their reflections on ISCP. I'm going to be practicing both trial MCRs and R2C2 to help trainers and trainees to maximise opportunities now.
Thank you, Rowan. There was a question right at the start about individuals getting very limited, if any, SPA time to conduct their supervision. And I would draw your attention to some of the documents out there, but perhaps most valuable for me has been using the trainer portfolio, the trainer bit section of ISCP, that actually I can start to quantify what I'm doing with trainees and can start to work out how much of my time is being spent assessing, setting agreements and reviewing performance. So I would urge you to use that. And if you go to the FST section, we've done a previous video about how to get the very most out of your trainer section of ISCP.
Thanks, Lisa. That's really helpful. I think we'll probably come back to a bit of discussion around time for training and what the faculty of surgical trainers can do, what the college can do, and you know, what guidance is out there. So I think we'll pick up time for training. So thanks for that presentation, Lisa. Again, really practical in terms of how we're going to use new ways of doing things. Some new terminology, perhaps for some, MCRs, CIPs, SIPs, and some may be very aware, others that might be a new language. But John, great to have you as clinical director of ISCP to explain a little bit more and also give us your insights to trainers and what trainers can be doing. And I guess particularly during this COVID time, but also in the longer term as the new curricula are introduced. I'm going to hand over to you. I'm not sure if you're going to show a presentation or just discuss, but John, great to have you. I know you've had a busy day, so thanks for joining us.
Well, thanks very much for having me, and thanks, Lisa, for the great promo. If you haven't heard of the MCR, SIPs and supervision levels and all those kind of things, hopefully by the time August comes, you're going to be sick to death of hearing about it. What I thought I would do this evening is just talk about why trainers or good trainers are really going to be needed in the next few months. So normally trainees progress at a reasonably steady rate towards CCT. And then this year this happened, and this has happened to the trajectory of training. And a lot of trainees have found from March onwards just about getting back to normal now, but again, perhaps going off for the next few months over winter, their training has been significantly interrupted. So the GMC have been very clear and very and quite rightly, that CCT level is remaining exactly where it is. You need to be as competent before COVID as after COVID to reach CCT and appear in the specialist register. But there are lots of pressures also on training at the moment. There's backlog of undone cases during COVID, pressure to catch up from managers, all the issues around providing training in the independent sector, to consultant operating, a second wave that seems to be rapidly approaching the shore, redeployment again perhaps, and probably really important factor both for trainers and trainees is morale. And so trainees need good trainers like they never have done before. This slide just shows some figures that we've only just got yesterday and today, so they're very early, but I thought I'd share them with you. Some numerical impact of COVID-19 on training. So in that graph on the left-hand side, I've just picked general surgery, shows the total operations in June 19 versus the total operations appearing in e-logbook in June 20, and you can see that the operations are less than half. And this affects all specialties. I could show you a graph from each of the specialties, and it looks almost identical. All regions of the country. It affects particularly those specialties that have a great part of their workload benign elective cases. It affects more junior trainees in particular, because it's those smaller cases that junior trainees are exposed to that have been put off and cancelled most. And also, you know, we focus a lot on numbers of operations, but remember that it's only one of the areas that is required to be a consultant surgeon, and training has to happen in all of those areas. And training, apart from possibly emergencies, has been affected by COVID-19 in all of those areas. This data just in today, that about a third of trainees who registered ST7 were awarded an outcome 10, either 10.1 or 10.2, and perhaps even more worryingly, about 1 in 8 trainees at ST8 have been awarded an outcome 10.2. So we can see that particularly if there's COVID impact again in the autumn and winter, that through the first and second quarters of next year, there's going to be quite a build-up of trainees not quite getting to CCT and having their competencies and progression to CCT and the trajectory changed, as on the earlier slide. Just to cover supporting everybody in independent sector training, all cases who are NHS patients are eligible for training. And another frequently asked question is about indemnity. NHS indemnity covers the trainee in the private sector for NHS cases. If you are experiencing a block to training in your local independent provider, then the path to take is to inform the TPD, who will inform your regional head of school. The head of school will take some action, and if he's getting no joy, will inform the dean quickly. The dean will then intervene, and if the dean is not getting any action, any response, and any moving of the block, then the dean will report this particular place to national bodies. In England, that will be NHSE and NHE, but each country has its own equivalent. So there will be action taken, but people need to know specifics to escalate it through this pathway. JCST ran a campaign over the summer on Twitter, no training today, no surgeons tomorrow. It's probably the longest hashtag I've seen, but it just says exactly what needs to happen. I think the first thing to remember is that, you know, when we're training, we were all trainees once. People took the time and effort to train us, and we are duty bound to return that favour. And the other thing is, now we're in pressured times and the trainee's trajectory has been deflected quite so much. Learning by osmosis isn't an option. We need to actively train, need to identify learning needs specific to each individual trainee. And to know that, you need to know what those needs are. You need to know what the curriculum is, and the certification and guidance and waypoints are on the JCST website. If a trainee has an outcome 10.1 or 10.2, then have a look in ISCP and see what the narrative is in that. It will identify the specific learning needs of that trainee with an outcome 10. As Lisa's talked about before, the MCR is going to be very valuable. It will demonstrate the gap between where the trainee is at this moment and the end of the curriculum, and identify what the trainee needs to do specifically for them over the next few months, and that's particularly important in COVID. So it's not coming into effect as part of the curriculum until August, but between now and August, it is a tool to provide extremely good, extremely detailed, bespoke feedback for each of your trainees. And the trainees can help themselves as well, because they can use exactly the same tool by logging on to ISCP and using the MCR tool to generate their own self-assessment and learning needs, which might be a little bit different for the ones that you generate for them. So when you meet with them, you can compare the two and work out a very effective learning plan for them. And actively plan training in all aspects of the job, not just theatre. When you encounter a trainee, I'd suggest that, you know, as training may be less available than it has been in normal years, that you get the most out of every encounter. You can do this by discussing beforehand what the trainees are going to do. COVID means that wait in the coffee room before the case starts is even longer than normal. So you've got plenty of time to talk about all kinds of things there. And then supervise them in whatever activity it is. And then afterwards, have a debrief, discuss what the trainees did. You don't have to write it down everywhere. You don't have to fill in a work-based assessment unless you like doing it like that. But just some contemporaneous feedback is really, really valuable. Perhaps using the format that Lisa just described, rather than the rather tired old Pendleton's rules. It may be that your colleagues aren't, you know, particularly focused on training at the moment, but everybody needs to pull their weight here. Morale's quite low, pressures are, as I described earlier. So everybody, I presume everyone that's tuned into this is a keen trainer, and that's why you're tuned in. But encourage and support all of your colleagues. Remind them that they were trainees and they need to return that favour to their trainees, and how desperate times are in training just at the moment. Two consultant operating seems to be quite prevalent at the moment, and they're seen as some trainees as a block to their training, but it's a great opportunity for training. We know from research that two consultant operating is far less stressful than one consultant operating, objectively so. And if there's two of you there, then it's much easier for you to take it in turns to train the trainee and identify what you need to do beforehand. It's just much easier to do it. So two consultant operating, a great opportunity to train properly. On on Twitter, these were some of the suggestions that came in, and you can have a read through them, but they're all reasonably straightforward and reasonably obvious. In any particular arena where you're training, then let the trainee do it, supervise them, and then give feedback. So in short, train in all the areas, and this is basically for all of us, whatever your specialty, a ward round, in outpatients, on the emergency take, in theatre, and not just the operating bit, but the WHO briefing, the debrief, the communication with the anaesthetist, etc., even booking the list, and also in the MDT or any other multidisciplinary meeting you have. Let the trainee lead parts of that, let them take the cases, and then give them feedback afterwards. Watch the trainees perform each of these activities, and really importantly, give feedback. Giving good feedback accelerates training and helps restore that trajectory. So how do you give great feedback and set specific goals? Well, one of the things is, apart from doing it on a day-to-day basis, is through here. Log into ISCP and click in the top right-hand there where it says Trial MCR, and it goes to those pages that Lisa showed earlier. So JCST, we are here to help. Everything that you need to see you through COVID is in this tab here in the JCST homepage, key documents, and it will take you to this where all the COVID-19 guidance that you'll need to see you through this is listed, and lots more besides. So I don't think people access it as much as they need to, but it's a great repository of all the knowledge and information that you need to help training, particularly at the moment. I just want to leave you with this, which came up on our No Training Today hashtag from Steve Cook, an orthopaedic surgeon. I'll just let you read through that, but just say I fully support what Steve says, as has a lot of other people, as you can see at the bottom of the tweet. But also, it's not just in theatre, it's in all areas. Thank you, Rowan.
John, fantastic. Thank you very much. And that's a great quote, indeed. Taking every opportunity, and I guess that's been brought into focus with COVID, but should be a good principle we should carry through indefinitely. So, John, thank you. I hope all of those presentations have stimulated some thought. I'd love to get some Q&A going. I know the team and the panel have been answering some of the questions as we've been going, but please, we've over 100 well over 100 delegates now on the webinar this evening. So please pop in your questions, comments, even if you want to make a comment, and we'll try and cover those. But I'm going to turn to Ceci first. We've heard a little bit of theory and principles and frameworks. We've got some practical ideas as well. And then we've got the real issue of during COVID and maximising opportunities. But Ceci, can I go back to you just to kick off our Q&A? Because I think you had a question for Gael.
Thank you so much, Rowan. Thank you, Gael and Jonathan and Lisa, for your very interesting presentations. I just have a couple of questions, please, if that's all right. So, Gael, I was really fascinated to see the framework that you put forward from the Faculty of Surgical Trainers. And in an ideal world, it sounds perfect. It sounds great to me as a trainee. But I wonder how we as trainees can be empowered to give trainers the opportunity to give us feedback, and how can we also try and maximize the framework to optimize our training, especially during these difficult times, and especially when the pressures of service provision can sometimes impede on training progression.
Thanks, Ceci. I think one of the important starting points would be to be conversant with these standards yourself. So be aware of what the ideal is, and I think that's a good starting point. I think also it's important to see as a trainee that you are aiming to become a consultant surgeon and also become a trainer yourself. So looking at that yourself, these are standards that are not just for trainers, they're for trainees to be aspiring to as well. And I think the starting point, like I say, would just to be conversant with what the ideal is as a starting point. I don't know if Jonathan wants to come in there with advice on how to help Ceci and other trainees in that direction, especially in the COVID period.
Yeah, so it is difficult and an opportunity down. So I think that, first is take charge of your training. And so don't wait for things to happen. Go and seek out opportunities. They might be a bit more difficult to find, but go and seek them. And then the other thing is that you have a learning agreement, and that learning agreement is a contract between you and your trainers. And so, have a look at that. And if you're not reaching what you've, not achieving what you've agreed in your learning agreement, then ask why, and then do something about that. And you can take, if you're getting no joy, you can take that from your AS, the TPD, and onwards. So I think, it's taking some responsibility and driving this yourself. There are pressures, and I think you have to be understanding of the pressures on trainers, but people should train you. You still need to make progress towards CCT.
Thanks, John. David.
Ceci, I think your question is vital to this conversation and the direction of FST. As already said, feedback is the breakfast of champions. And on the ISCP website, my predecessor and Gareth Griffiths had the insight to map the framework to questions that you as a trainee can fill in. And what Gareth supplied me, and I'm going to invite John to comment as well, 1,465 surgeons have logged onto the trainer site on ISCP. Surgeons form 9% of the workforce, and we're all involved with training. Of that, only 250 people have started to fill in a profile, and a mere 40 have completed a trainer profile on the ISCP website. Now, if we're going to be considered professional trainers, and as Lisa alluded to, demonstrate the time and dedication that I know trainers are putting in, this is a fabulous tool for all trainers to use. Robin Payton is on council, who is on the executive. He describes, and he won't mind me saying, and he laughs, that he was a Luddite when it came to this. And after one of our executive meetings with Lisa, he went off and filled it in and is delighted with the response. And I think the first responsibility of trainers is to actually engage in that rapport and invite feedback.
John, do you want to comment on that? You know, the use of ISCP for trainers as well as just for trainees?
Yeah, well, I think he's been there for a while, and engagement hasn't been quite as widespread as we would have hoped. I think it's a great tool. I really like it as a vehicle for getting anonymous feedback from trainees. So what happens is that you nominate trainees until you get to 5. Emails go out to them with a questionnaire, and then the feedback returned to you. It's incredibly valuable, and you know, some of it's great and some of it's slightly harder to read, but that's what feedback's about, and then you should act on that. The other great thing about it is see how well you do compared to everybody else, is how quickly you get back work-based assessments, how quickly you respond to those. So it brings out that sort of competitive side in me, and then you can put down your likes and dislikes as well. So if you fill in your peccadillos and predilections for theatre and ward rounds and things, then trainees know what to expect when they get to you. So that might make that initial relationship, you know, get you off to a better understanding when you start. So I think it's a great tool. It's not hard to find on ISCP. Just look along the bar at the top and follow the links. And it doesn't take very long at all to fill in. And I found it a really useful thing. And I think the trainees have found themselves surprised that they've been asked for feedback on my training, but really enjoyed giving it, perhaps slightly too much sometimes.
I agree with you entirely, John, and it's a shame that this very valuable tool that was set up with David Pitts and Craig MacLean is not used. And to encourage people to use it, the Faculty of Surgical Trainers has included it in the scoring system for when you apply for membership or fellowship. And we strongly encourage people to do this. As you say, Jonathan, you take the rough and the smooth, but it's the only way to develop.
Okay, so a lot of opportunities. Maybe some of our trainers on the call this evening or on the webinar will be keen to go and explore and look at that, and look at the ISCP website as well as FST. So a question for CCAR here: what specific measures taken by FST and the GMC to ensure we are professionalising surgical trainers? What are the levers available for trainers to be used locally? Some of this might be around time for training, where there is guidance in things like the Gold Guide. It should be 0.25 PAs per trainee. But David, just coming back to you in the faculty, or Gail, what can FST do to encourage professionalisation, other than joining up and becoming a member or fellow? But yes, is there any levers that they can use in their trusts, in their health boards?
The first important lever is to use the ISCP trainer website and demonstrate that you are training. It actually maps to the GMC requirements for training, and it helps with your appraisal process. And I think the change in culture has got to come from the trainers demonstrating a willingness to develop themselves as trainers, but also to learn the tools for training. And we hope to be able to soon announce a partnership with a leading organization to help signpost people interested in developing their theoretical skills in training. What I did blog about at the beginning of the week was a comment made by the CEO of the Wye Valley Foundation Trust, Glenn Burley, and he was commenting that he was in his local Hereford County Gazette as a CEO of a foundation trust, that he was extremely proud that one of his surgeons won the Silver Scalpel Award last year. To me, this indicated the culture change that is required at that level as part of the system, that the system and CEOs recognize the value and importance today and tomorrow of having the very best trainers. And when I read that, and Glenn provided a comment on that, which is on the website, I jumped for joy, because this is the beginning of something very important.
Excellent. Super. Okay, Lisa, I'm going to come to you with one of the questions raised by Tim Graham. So as most will know, it can be challenging, but what happens when consultant assessors disagree? How do we keep MCRs as formative, not summative, or are they summative? Oh, you're still on mute. Sorry, Lisa.
That's a really interesting question, because the MCR meetings should take place halfway through a placement and then at the end. Now, the one halfway through is very much formative and is designed as a vehicle to help a trainee work out how to get the very most out of the second half of their placement. The end, it could be argued, is more summative, because it is a judgment about where they've got to at the end, and that will inform the assigned educational supervisor's report and then ARCP. Now, the question about disagreement is a really good one, because there's also the worry about somebody who is rather overbearing, maybe one of the members of the MCR who does a lot of talking over other people, and if they're the lead clinical supervisor, just really writing what they think. So there is a 2-week grace period after the MCR has been completed by the lead. It goes out to all the other people who have made comment, and there is two weeks, I think it is, John might correct me, to add, take issue, make changes to that MCR.
Okay, thanks, Lisa, and helpful comments. I'm going to keep firing because the questions are piling in now, so I'll try and get through as many as possible. So one for you, John. Any thoughts, comments about why NOTS and the NTS work-based assessments have fallen off? ISCP may send the wrong message about assessment and feedback on non-technical skills. And there was another comment earlier about the importance of non-technical skills and how we're capturing that in the, if you like, new way of providing feedback. Any comments, John?
Or not? Good evening, Simon. I think probably. So NOTS it isn't. We put it in the curriculum submission, and unfortunately, it wasn't approved by the GMC. The link to NOTS is still on ISCP, which takes you to the NOTS site hosted by RCS Edinburgh, and we do think it's a very good thing, and we'll support it. And in the future, we may put it in a curriculum revision. But one of the GMC's comments was about evidence around NOTS working. Now, it seems self-evident, but the GMC want absolute objective evidence. So what would be helpful for everyone involved in NOTS, which again we fully support, is to gather evidence about how it works, about its success, etc., so that we can put that in a properly supported curriculum submission to the GMC.
I guess, John, it still is in some of the generic professional capabilities. Team working and situational awareness are generic. So I guess they do need to be captured somehow. Who's responsible? Is that clinical supervisors, the educational supervisors? How do they keep their mindset?
As Lisa showed, in the first part of the MCR is assessment of generic professional capabilities in 9 domains. And so people who work with the trainee every day will be able to comment on those. And I think one of the great advances of the new curriculum is that for the first time, we're properly able to capture performance in those non-technical areas. And of course, this is, that's the whole point of NOTS, isn't it? This is the thing that gets people into trouble particularly in the early years of being a consultant. What we need to be able to pick up those behaviours, and that sort of realisation is the first step along the way. People don't know that they're doing things wrongly, and so when I told, I found that people turn themselves around without too much help. If they won't do that, then we can help them to see things differently and to correct their behaviour. So it's all there. It can be picked up from the first MCR, and I think that we'll find that a lot more strongly when the new curriculum comes in 2021.
Thanks, John, and we look forward to that. So, Gail, I'm going to come to you. And there's a few either comments or questions about the 7 standards that you talked about, and Anthony mentioned in my trust during the consultant appraisal, all trainers are assessed according to the 7 standards, and you have to show evidence of meeting these standards to pass or satisfy the educational aspect of your appraisal. So that seems to be a trust working really well and using this. How do you think we can rule that out more widely?
Well, that's something that we're working on currently in the FST, because we're partnering with the regional surgical advisors, the College of Surgeons of Edinburgh has all the regions in the UK. There's a surgical advisor from the college there, and we're working with them now to make that also an ambassador for the Faculty of Surgical Trainers, and actually rolling out these standards to be more accepted by trusts in the educational appraisal that is part of everyone's annual appraisal who is registered as a trainer with the GMC.
Okay. And John, coming back to you, and Shri has made a couple of comments again, one saying how they use the FST standards, but another one, how can JCST work with the GMC to ensure trainers are recognised on the GMC registers? There seems to be a time lag. So, you know, as many know, it's now a requirement of the GMC to get recognised for training if you're holding a clinical supervisor or educational supervisor role. Does JCST have to do anything more? Does FST have to do anything more to get that recognition, if you like, recognised? I don't know whether that's a GMC issue or whether there's anything JCST are doing to help and support that, or is it down to deaneries and local HE, NES offices, etc., to facilitate that?
Well, so I think JCST support that. Anything that improves improvement, anything that brings improvement in training, we strongly support. But it's not really within our remit to implement this, and needs to be done through schools and SEBs, statutory education bodies like NES and HE, etc.
Okay. Okay, here's a general question. Anybody feel free to pick up. But we're taking, as somebody said, we're taking core trainees and specialty trainees to the private sector. What about students, medical students, taking them to the private sector? Does anybody have a view? Gail?
So in Oxford, we're just finalising the paperwork for medical students to be able to go into the private hospitals for NHS cases to be trained there, because currently there's no medical students coming to theatre at all. So we're just in the final stages of getting that approved, because we moved to the private hospital. I'm a breast surgeon. We moved all our operating to the private hospital when the Department of Health mandated the private sector to help during COVID. We're still there, and we'll be there till at least the end of the calendar year. And a few of the other specialties are also working there. So it's a great opportunity to use, and we're just finalising the paperwork with the medical school to get them on board there.
Yeah, so the medical school are presumably have to be involved in this. You know, I know from postgraduate surgical training, it's been the statutory education bodies that have brokered a lot of agreements, as John said earlier, with NHS EI, and again in Scotland we've done something similar for postgraduate, but I think for undergraduate probably needs to be done at a university for placements and followed through. There's a really interesting question here from Jay. I'd appreciate your views on how we can support trainees in surgical departments that are short of consultants. And we do know that when consultants or there's vacancies at the consultant level, it does impact training. But they're a small department. There's 2 locums and 3 substantive consultants, 2 of whom work part-time with reduced hours. So clearly have to deliver a clinical service. And it says they lost their trainees because of this a year ago, but they want to rebuild an environment conducive to training. So Lisa, have you thoughts? How do trainers who have an interest, a passion, they want to start and build something up, how do you feel, or any advice for them as to how they do that and demonstrate that they're committed and want to get trainees back again? Have you any thoughts or advice, Lisa?
I think that must be so hard, because they're trying to keep the service going, and that's difficult enough for everybody without having too few people to do it. I wonder whether some of the quick wins to really demonstrate commitment are just simple measures like getting all trainer profiles completely sorted. They're the gift that keeps on giving, and I reckon that you can do something decent in 15 minutes. So you get all your ducks in a row, real clarity around how the department would plan to use the standards for surgical trainers, how they plan to get ready for the new curricula. So all the educational things are in place, but I feel for you hugely. I think you must be spending most of your time just trying to look after patients.
Thanks, Lisa. Listen, it's gone 8 o'clock. We've just about spent an hour. It's been fascinating. There's been great questions. Thank you to the panel. David, I'd love you to just give some thoughts in conclusion. There's been a few people interested in what's this FST about. How do they find out more? How do they sign up? How do they join? What does it mean? And you mentioned right at the start the conference. You know, FST runs an annual conference, and you'd maybe give us just in closing one or two lines about that and how people can find out information about the conference. This is all about supporting each other, giving each other support and doing what we're all trying to do. But David, any thoughts from FST?
Thank you very much, and thank you for the interest. And we welcome anybody interested in developing their skills in teaching to join the Faculty of Surgical Trainers. We are looking at all avenues of adding value and growing and nurturing our trainers. What is clear over the years of running the Silver Scalpel Award is that good service and good training go hand in hand. And I don't think there is a tension in that at all. What is the basis of all of this is good communication. And I'm delighted that we're hosting our first online conference in 2 weeks' time on the 16th on communication. And we have a global speaker headlining that, Bob Chapman, whose theme and message is Everybody Matters.
Thank you very much, David. Thank you to all our panelists. Really grateful, Ceci. I know there's probably one or two more questions we can squeeze in, but I suggest if people want to follow up either with John and ISCP, you can send through the links, or also inquire about FST through the Royal College of Surgeons of Edinburgh website. So hopefully everybody who's been signed up and joined us this evening, you've been encouraged by all the work going on and the thought and effort being put in by so many to improve surgical training and to deliver good surgical training despite COVID. But I want to just finish by thanking our panel, David, Gael, Lisa, John and Ceci. Thank you very much for giving up your time and joining. And can I wish everybody a great rest of the evening, and join again next Monday, 7 o'clock for the College in Your Kitchen. So good to see everybody, and good night.